You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 29th, 2023. This week, I'll do some reader feedback, talk about leadless pacemakers, ABIM, SGLT2 inhibition, peri-operative MI after cardiac surgery, and the AHA has announced their late-breaking clinical trials for meeting coming up in 6 weeks. First, some reader feedback. Matt Gross left a comment reminding me that I misspoke regarding the alirocumab trial called Odyssey Outcomes. I said that CV death and death were similar, but in fact, Matt was right that overall death was actually lower in the alirocumab group. It was 3.5 versus 4.1%. I also agree with Matt that this was a likely spurious finding, as there was no difference in cardiovascular death or death from coronary disease. And I would also add that in the overall death category in the evolocumab trial called Fourier, overall death rates were slightly higher in the active arm, 3.2 versus 3.1%. So the bottom line, I think, is that the PCSK9 drugs reduce LDL cholesterol on top of statins and induce modest reductions of non-fatal cardiovascular events. Thanks for listening so closely. I also received a number of emails regarding my frustration over the misuse of coronary artery calcium scans. Now, the general consensus was agreement with me, but one message I heard in these emails was that tests are just tests. Tests are not bad or good. What is good or bad is their use or misuse. And so the blame for overuse and misuse of coronary artery calcium scans, I think, is on the human clinicians. Now, I remember one of my mentors, Dr. Bill Miles, reminding me of this when I was railing against the wearable cardiac defibrillator. Bill said, John, the test or treatment has no properties. It is the clinicians that deserve the blame for misuse, if there is misuse. So I again reiterate my plea to the key opinion leaders in the coronary calcium space to put out stronger statements regarding the proper use of coronary artery calcium scans, and that is to use these scans, if you're going to use them at all, as a risk prediction enhancer for preventive therapies and not the beginning of a downstream spiral of cardiac testing. And a final announcement, I'm broadcasting today from the wooded hills northeast of Oslo, Norway. We have had the first day of the 7th annual meeting of the Norwegian AFib Research Network, and I'm honored to be able to speak here, and I'm impressed by the basic epidemiologic and clinical research going on here. Thanks to leaders Dr. Ingrid Kristoffersen and Amjad Tveit for the kind invitation. It's very exciting to be in Norway for my first time. So, all right, first topic today is leadless pacing. The journal Europace published this month a study from a group at Albert Einstein in New York comparing outcomes after standard single-lead ventricular pacing versus leadless pacing. Now, this study got a lot of attention on Twitter amongst some pretty high-profile people. Leadless pacing is now a mature technology, and the authors point out that there have not been randomized controlled trials comparing leadless to standard transvenous pacing. So they attempted to answer the question of which device leads to better outcomes. Now, they concluded after their study that there was a much higher rate of in-hospital mortality and complications with leadless pacing versus transvenous VVI pacing. They then say that this may have been related to higher comorbidities in the leadless pacing arm. I think they are surely correct. So after I tell you about this study, I'm going to ask a question. So the authors decided to query the National Inpatient Database from 2016 to 2019 to try and assess outcomes after patients who received either a leadless pacemaker or a standard single-lead transvenous VVI pacemaker. They used ICD-10 codes to count these complications up. Now, this query led to a very large sample size. More than 27,000 patients had transvenous VVI pacing, nearly 8,000 had leadless pacing. The average ages was 81 years in the transvenous group and 77 in the leadless pacing group. Now, when you go to Table 1, patient characteristics, I think that you see the main flaw in this study, and that there were vast differences in comorbidities, with the leadless pacemaking group having far greater numbers of comorbid conditions. Now, of course, the authors did propensity matching, which is a technique that attempts to find similar groups matching based on baseline characteristics. But still, these are going to be retrospective, non-random comparisons. And they indeed report much worse outcomes in the leadless group. For instance, the inpatient mortality, the odds ratio was 1.63, so 63% higher. There were 7.5x more vascular complications in the leadless arm. There was more venous thromboembolism and more cardiac complications in the leadless pacing versus transvenous pacing. So my comments are that this is a problematic line of research. Leadless pacing and transvenous VVI pacing are clearly used on different types of patients. Leadless pacing are used more often in very ill people, for instance, in patients who are at risk of infection, such as patients with end-stage renal disease on dialysis, patients who have recurrent bacteremia, and having those conditions puts a patient at a higher risk of a bad outcome, such as inpatient mortality. And these adjustments can only do so much to balance the covariates, right? The outsized rates of worst outcomes strongly suggest that it was not the device that caused the worst outcomes, but the sicker patients. My question, therefore, is why do and publish such a study? It is so clearly affected by baseline differences. What's more, in the modern era of conduction system pacing, there would be another crucial factor affecting head-to-head leadless pacing versus transvenous VVI pacing trials, and that is that the transvenous VVI pacing arm is going to also benefit from conduction system pacing and the lack of dyssynchrony that comes with that. I'm going to suggest something here that might be controversial. Since leadless pacing is so often used as a niche device in very special patients, perhaps we don't need a randomized trial of leadless pacing versus standard pacing. Let me know what you think about that proposal. All right, second topic is there was news on the American Board of Internal Medicine board certification front. Now, there's a lot to say here, and I'm going to keep it brief because this topic affects mostly U.S. cardiologists. Last week, I mentioned that the ACC Heart Failure Society, Society for Cardiac Angiography, and Heart Rhythm Society have began talks to create their own dedicated cardiovascular medicine board certification. Journalist Steve Stiles covered this story, and it is the most popular article on the heart.org Medscape Cardiology website at this moment. And I think it's big news because this new, independent, self-governed entity would supplant the monopoly held by the American Board of Internal Medicine currently. And the oversimplified background for all listeners is that certification of internal medicine doctors and its specialties, such as cardiology, has long gone through the ABIM, which is overseen by a larger entity above that called the American Board of Medical Specialties. Now, the problem, I think, the core problem from the perspective of practicing doctors is that certification once meant passing a single board exam after training, and then all you had to do was keep up with routine CME. Then ABIM, without any representation from practicing doctors, said, nope, now you need to pass this recertifying exam every 10 years. Medicine changes, and so we need to test you every 10 years. But even that wasn't enough. ABIM then added things called maintenance of certification, which are more frequent examinations and require more assessments and more fees, of course. Now, another problem, cardiologists learned about things like rent-seeking and regulatory capture because much of the power that ABIM held came from the fact that it had been written into the Affordable Care Act, into law. And get this, the professional societies like ACC, like Heart Rhythm, had conflicts because they made money from the ABIM by selling test materials. Now, I really never thought anything would change, but enough doctors spoke publicly, mostly through social media channels, that professional societies might have felt threatened enough to embark on these changes. It remains to be seen what these new board requirements will be, but it is a good start. And I think one of the main lessons is that social media offers new ways of bringing about change. Now, since Steve wrote his review, dated September 22nd, we have now learned that the CEO of ABIM, Richard Barron, is retiring. That's interesting. And yesterday, the American Society of Hematology also sent similar letters to ABIM, suggesting that they too were interested in independent board certification assessments. So it looks like I might have been wrong about the situation because I thought it was pretty hopeless that we doctors had no collective power against entrenched bureaucracy. Now, we shall see how it goes. I'm also watching the movement in the UK to affect changes in the NHS. I mean, I think there is great hope for positive change if only our profession could put aside personal goals for the greater good. Professional sports teams do this, but I've yet to see doctors do it, so we'll see. All right, third topic today is news on the SGLT2 inhibitor front. FDA this week gave approval for the use of Empagliflozin for a new indication that is treating adults with CKD at risk for renal progression, even in the absence of type 2 diabetes or heart failure, just CKD indication. And this is the second approval for prevention of CKD progression, as dapagliflozin had received that approval back in 2021. This new approval was based on the EMPA-Kidney study, published 11 months ago in the New England Journal of Medicine. In brief, EMPA-Kidney randomized 6,600 patients who had CKD as measured with two criteria. They either had an eGFR of at least 20 but less than 45 milliliters per minute per 1.73 meters squared of body surface area, or an eGFR of at least 45 but less than 90 millimeters with a urine albumin to creatinine ratio of at least 200. At 2 years, empagliflozin reduced the primary composite endpoint of progression of kidney disease or CV death by a significant 28% relative to placebo. So this is now the fourth FDA-approved indication for empagliflozin to review. That drug is FDA approved for reducing CV death and heart failure hospitalizations in patients with heart failure regardless of EF. It's indicated for reducing CV death in adults with type 2 diabetes who also have known cardiovascular disease. And it's also approved for reduction of blood sugar along with diet and exercise in adults and children greater than 10 years old who have type 2 diabetes. A couple comments. One is that cardiologists are now clearly prescribing these drugs for heart failure, but a lot of our non-heart failure patients, say those with coronary disease or AFib or PVCs, also come in with CKD and type 2 diabetes, and we ought to be on the lookout for patients who are not on these drugs who probably should be considered for these drugs. Thing is, a lot of times I have contacted the primary internist about starting an SGLT2 inhibitor for one of these indications like CKD or type 2 diabetes. And the response that I've been getting is that, look, John, we've already tried these patients on them and the patient could not afford the drug. So cost remains a headwind for using these drugs. But another problem we're seeing, and I wonder if you're seeing it too, is that I sit on the peer review committee at our hospital, and we have seen a number of cases of non-hyperglycemic ketoacidosis due to SGLT2 inhibitors. And the problem is that patients come in with generalized symptoms and these super low bicarb levels and high anion gaps, and the recognition has been slow in some cases and treatment has been delayed. We're sending out messages, e-messages to our staff to be on a lookout for this. So I guess the main message is for increased alertness to having these low bicarb levels and high anion gaps and earlier recognition of this issue. And finally, the increased issue we're seeing with this complication, I think, speaks a little bit to the difference between clinical trials and real-life practice. Metabolic acidosis due to SGLT inhibitors may not have been a major problem in trials because, of course, in trials there are research nurses and people who really know about this problem. Patients are followed very carefully, and this careful follow-up is different environment than the real-world practice. And so I think practicing doctors are going to get the hang of it eventually, but right now, I guess just be on the alert for ketoacidosis from SGLT2 inhibitors. Our next topic is peri-operative myocardial infarction, specifically peri-operative cardiac surgery myocardial infarction. It's super weird because that modern technology has made things harder in this realm, I think, not easier when it comes to the diagnosis of something like MI after cardiac surgery. When I started, it was simpler to diagnose this MI after heart surgery because you had to have serious focal STT changes on an ECG or major new wall motions, abnormalities on an echo. I mean, enzymes might help, but CKMBs, these were always high after surgery. And it was important to make this diagnosis. I think it's still important to make this diagnosis, even though cardiac surgery is better because, rapid reoperation or perhaps PCI might help fix a graft failure. The problem is obvious, right? Surgical trauma causes release of cardiac troponins. The question is how much cardiac troponin is acceptable and how much is enough to predict mortality or initiate acute treatment decisions. Now, though, the advent of more sensitive troponin assays have complicated the matter even further. And the complications transcend clinical practice, and it gets into trial interpretation because a lot of the controversy surrounding the XL trial, remember CABG versus PCI in patients with left main coronary disease, a lot of that controversy turned on the definition of MI in the two groups. Well, recently, Jack has published an important effort from a group in Innsbruck, Austria, first author Leo Pols, and this was a single-center study with a consecutive group of more than 8,200 patients who had cardiac surgery, and the authors attempted to sort out new definitions of perioperative MI after cardiac surgery using high-sensitivity cardiac troponin T measures. Specifically, they plotted the relationship between post-op troponin levels with 30-day and 5-year mortality. They adjusted using a Euro score, and they considered thresholds for isolated CABG, aortic valve replacement, and other cardiac surgery. Now, this is complicated work, and it's hard to make it simple, but I will try. They measured high-sensitivity troponin T, the Roche Diagnostics brand, they pre-op and then post-op for 3 days. The highest value they found was used for the comparison to 30-day and 5-year death rates. Now, their main figure requires closing your eyes, well, not if you're driving or cycling, but imagining a plot with an x-axis that has the troponin levels, the y-axis, the hazard ratio for, say, 30-day death. And the plot begins with a line going up gradually, and the higher the troponin, the greater the hazard ratio, and eventually it plateaus. And of course, the line has confidence intervals, and when the lower bound of the confidence interval reaches a hazard ratio of something greater than 1.0, or then maybe greater than 2, the authors can define a level that is so many x above the upper limits of normal. Now, you probably won't remember the actual numbers, but here they are. High-sensitivity troponin T value upon surgery, which was associated with an adjusted hazard ratio of more than 1.00 for death at 30 days, was 1,236 nanograms per liter for CABG. The authors then tested the utility of these measurements with ROC curves. The highest predictive value of the high-sensitivity troponin level for CABG patients was an AUC of 0.79. So again, for ROC curve, 0.5 is a coin toss, 1.00 is perfect. So, pretty good predictive value. Then the authors went on to try and predict the threshold to identify what is an actual peri-op MI. And they found the threshold for high-sensitivity troponin T levels for predicting 30-day mortality was 2,835 nanograms per liter, and that's for isolated CABG. And then within this multivariate regression model for the 30-day mortality, high sensitivity troponin levels above the cutoffs resulted in a hazard ratio of 12 for isolated CABG. Now, post-op troponins in this study had little predictive value for 5-year deaths, which you kind of expect. So my comments: this is pretty hard work. An editorial from the McMaster's group that accompanied this paper in JACC helped a bit. And the editorialists cite a similar effort that they did with something called the VISION study. And they published this work in New England Journal of Medicine in March of 2022, and I'll link to it. It's a similar type of study. VISION had the same goals to sort out threshold levels of cardiac enzymes after cardiac surgery. Now in VISION, they had more patients, 13,000 versus 8,000. They also had multiple centers, and they used different high-sensitivity troponin. They used troponin I, not T. Now, the main graphs of the VISION paper, though, were similar. The x-axis has the troponin levels, the y-axis has the hazard ratio at 30 days, and the plot gradually goes up, and you select a troponin level associated with higher hazard ratio for death. And the VISION authors found that, quote, among patients who underwent isolated bypass, coronary bypass, the threshold troponin level measured within 1 day after surgery that was associated with an adjusted hazard ratio of more than 1.00 for death within a month was 5,670 nanograms per liter. That's a level 217 times the upper reference limit. So here is one commonality that I found. And if you take one thing to remember from this podcast, it is that both studies, the JACC study from Austria, the VISION study in New England Journal of Medicine, find that the threshold troponin for correlating with higher rates of death at 30 days is much, much, much greater than the current thresholds. In the Austrian study, it was 170x the upper limit of normal, and in VISION, it was 218x. So I guess at minimum, in the high sensitivity troponin era, we will need to hold off on diagnosing perioperative MI after CABG unless there are much greater levels of enzymes. But even then, the prediction is far from perfect. Clearly, I think we need more work in this area to better define the levels and outcomes. Now, for research, I wonder whether a consideration is to simply remove perioperative MI or even all MI from composite endpoints looking at this. There are so many variables that are involved here, right? The type of surgery, the timing of the measurement, the type of assay, and even then, the level of enzyme tells us little about the cause of the perioperative MI, such as simple trauma from surgery, prolonged pump time, or even graft failure. At least until we better understand the relationship between high-sensitivity troponin releases and outcomes, I wonder about the utility of using perioperative MI in trials. And it's funny, the better we get at biomarkers, the less valuable MI seems as a surrogate outcome measure. I'm happy to hear more people who are experts in cardiac enzymes. Please, if you don't agree with this, let me know. I can learn more from your comments, so keep me posted. And finally, before I close, let me just say that the American Heart Association meeting coming up in early November has announced their lineup of late-breaking trials, and gosh, there's going to be some big news from this meeting. We just learned that at AHA, we'll hear the data from the SELECT trial. SELECT trial was a cardiac outcomes trial of semaglutide in patients with obesity. We already know it met its primary endpoint, but this is going to be a really important trial. We're also going to learn, and I'm very excited about ORBITA 2, which is ORBITA 1 in more complex coronary artery disease. And so we're going to learn more about the placebo-controlled effect of PCI on angina. There's a study called CARDIA SSBP, which is a randomized crossover trial looking at sodium and systolic blood pressure. Sodium and systolic blood pressure is always a hot topic. Last week, I told you about Azalea-TIMI 71, a phase 2 trial of the factor 11 inhibitor abelacimab versus rivaroxaban in patients with AF. We'll hear about that data. And perhaps the biggest trial of all in the AFib space is we're going to learn results of the Artesia trial. Artesia is apixaban versus aspirin in patients with short duration AFib. This came up in my discussion after my talk here in Norway. I presented results of the NOAA trial, which found really no benefit to edoxaban versus placebo in patients with short-duration AFib, but Artesia has some different types of trial characteristics, and it could bring different results, and we'll be in a real pickle if NOAA shows no benefit to treating short-duration AFib and Artesia comes up with some benefit. So we're going to have to really put our thinking hats on when AHA comes along. So that's it for this week in cardiology. As always, I'm grateful that you listen. Remember, if you like this podcast, please take the time to give this a rating on whatever podcast app you use. Write us a review. Write me a comment. Teach me things I'm happy to hear. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.